Thank you, Arnold. Hi, I'm Bill Fearon from Stanford, and welcome to our coronary physiology session. We hope that this will be an interactive session, so please, after each talk, we'll have a few minutes to ask the speaker questions. If you have one, just raise your hand, and a mic will come by soon. I think Manoj will be circulating. So yeah, we want to keep it interactive. We're going to go from the epicardial vessel to the microvasculature and spasm and everything in between. So we'll start off. My co-moderator, Arnold Seto, is going to give a talk on epicardial physiology pitfalls.
All right, so we're going to start with the very, very basics. These are my disclosures. None of them are relevant. So key physiology pitfalls are technical, pharmacologic, and physiologic, and we'll go over each of these. And we think we know how to measure FFR and IFR. The common steps are to heparinize, administer nitroglycerin, equalize the wire, measure only after you, of course, flushed it, closed the TOE bores, and taken out the needle introducer with the guide disengaged ideally, and then you do a pullback and check for wire drift. This is what happens if you leave the needle introducer in. Obviously, the aortic pressure should never be below the distal pressure, so this is obviously wrong. If you leave contrast or blood in the guide, this is what happens. Contrast causes a waveform that's damped, and the average is actually lower than, again, the distal pressure. Similarly, just leaving blood in there causes a damped waveform, although it doesn't necessarily change the average. Signal drift happens in up to 17% of cases, and especially with solid-state sensors. And this is very annoying, and because you don't necessarily discover it until after you pull back the wire. In some cases, it becomes even more and more severe, even over seconds, and sometimes you need to pull out a whole different wire. Guide catheter dampening and disengagement is really important. If you have a damped guide, you'll have a ventricularized waveform, and the FFR will be falsely negative. There's no dicrotic notch in the most extreme forms, and the diastolic waveform is, like I said, ventricularized. And when you disengage the guide, the full extent of the difference is apparent. So even if you don't see this apparent ventricularization, just routine guide disengagement can increase your FFR positivity rate. So in this one, you can't necessarily see the ventricularization, but just routine disengagement on two different cases causes the FFR to drop another 0.06. So if you're in the borderline zone, especially, you need to disengage the guide to get the full effect of the pressure change. Our leader here, amongst all the other areas that he has studied, Brilakis, has shown that side holes don't cover this enough, and so routine disengagement of the guide is actually the best thing to do for avoiding damping. So this has actually been shown in large studies. The contrast studies showed that in 616 patients, even in expert centers, 17% of people had signal drift, 5% had guide dampening, and 4% had waveform distortion, like leaving contrast in. So disengage the guide. Another tip is to change your settings to make sure that your FFR is measured for a 3 to 5 beat average. If you don't do this, then you'll have a lot of fluctuations from beat to beat, and the average is better. All of our studies in FFR have used a 3 to 5 beat average measurement, which reduces the effect of this signal beat variation. What about pharmacologic issues with hyperemia? Basic question, that's one of my favorite, is where do you check the FFR? If you check it at point A, it's 0.68. If it's point B, it's 0.76. And if you wait for stable hyperemia, it's 0.85. And for a long time, we didn't really know the answer to this. We actually had recommendations to do any one of these things. But and this is actually kind of concerning because the stable value is not always the lowest value of FFR. These two studies showed that the stable value, which we are supposedly using for our pressure pullback curves, is actually on average 0.04 higher than the lowest value of FFR. You can imagine the body's just trying to fight being fed by a fire hose. If you're being sprayed by a fire hose, you'd probably try to react to it as well through different autoregulatory mechanisms. So this is a concern. And then we also experienced, and we described that you actually have cyclical hyperemia in a large number of cases. Even with continued IV adenosine, you actually had decreases in peak velocity, so you couldn't sustain that hyperemia despite administering continued adenosine. This was confirmed by Niles Johnson in 2 different studies where he found that IV adenosine only produces stable hyperemia in 57% of cases. And so within reason, he said, always take the minimum FFR value, which is conveniently what the machine tells you anyway. My other tip is that if you're not getting stable hyperemia, then maybe you shouldn't be using IV adenosine. IC adenosine, intracoronary, is faster, causes less bronchospasm, flushing, fewer side effects, and is much easier to do. You just need to make sure you disengage the guide as described earlier. Another advantage of IC adenosine, it turns out if somebody's drinking caffeine, you may have a very bad situation where you give IV adenosine for 5 minutes and you see no effect on the FFR value. But when you know there's an effect because with contrast even, you got a contrast FFR of 0.93. And then finally, when you give IC adenosine, the FFR is 0.89. And when you can increase the dose and give a larger dose, you can actually get it even lower. This particular patient had a mild lesion, but he was admitted to having a cup of coffee in the morning of his cath and was a daily 2 to 3 cup coffee drinker. Here's another case where he wasn't necessarily drinking coffee, but this patient had end-stage renal disease, hypertension, and angina, has some LVH, and for 5 minutes, IV adenosine was administered and had no effect really on the resting ratio. It didn't change at all to 0.94. But we knew again that the contrast, if the contrast was given, it would actually cause a mild hyperemia. And so we gave IC adenosine, 90 micrograms, and drove this down to 0.85, and then a much larger dose, 180 micrograms, 0.78. So IC adenosine allows you to give it faster, it allows you to give larger and larger doses, and then ultimately get the answer that is truly maximal hyperemia. A more common problem is residual hyperemia. So we have these resting ratios, which are supposedly to be measured in the resting state when someone's not having any hyperemia. But not infrequently, of course, if you are too much in a rush to check your IFR, if you've given contrast, nitroglycerin, or even saline, for the first few seconds, the IFR is showing the effect of hyperemia, residual hyperemia. So all the studies of IFR actually said that you have to wait 30 to 45 seconds. So even though it's supposedly faster than FFR, if you don't wait those 30 to 45 seconds, you'll have a falsely positive IFR. I like to tell people that this is the best way to cheat IFR. If you see someone doing this, then they're actually trying to make it more positive in case they want to stent. So in this example, the IFR is 0.80 when in the first minute, or in the first 10 seconds after injecting contrast. But then you wait a little longer, about 8 seconds later, it's 0.83, and you wait another 30 seconds, it's 0.86. So the true value should be this. The clean value is without any hyperemia, 30 to 45 seconds after giving contrast or nitroglycerin. So the pharmacologic issues with hyperemia include, as I mentioned, residual hyperemia with non-hyperemic pressure ratios. You need to wait 30 to 45 seconds. You should take the lowest value for truly hyperemic FFR. I question the reliability of FFR pullbacks if you have cyclical hyperemia. However, it's been described that you can double the IV dose to 280 mics per kilo per minute, and that may resolve this problem. You should definitely make sure they're not drinking caffeine before your study. And then if you have adenosine resistance evident, then you can give IC adenosine, or as I mentioned, a higher dose to overcome it. So the more complex issues are, the more we study this, the more we realize that coronary disease is, of course, a diffuse disease. Even though we have a focal treatment in the form of stenting, and we'd like to think that most coronary disease occurs in the first 2/3 of the vessels, in many patients, it's more diffuse than that. So you have focal disease on the left and diffuse disease on the right. In a simplistic model, of course, the patient on the left is going to do better with stenting. The patient on the right might be doing better with medical therapy or CABG. One of the goals with the post-PCI physiology is that you could predict with these models, like drawing the stent, what would be the IFR after stenting, or what would be the FFR after successful stenting. And this model works quite well when you have focal disease. In this case, the IFR was 0.69 at this lesion. It looks relatively focal, and when you stent it on the lower left, the stent seems to resolve the issue, and sure enough, the IFR is 1.0, so it worked. Post-PCI physiology was accurately predicted with this pressure pullback. And so the thought was that crosstalk, meaning the interaction of two different lesions, could be better with resting physiology than with FFR. And the concept here was that with a resting or stable degree of flow, you could remove one lesion and not have an sudden increase in the significance of the proximal lesion. In contrast with FFR, because of the hyperemia, you would have a much higher rate of flow, and that would potentially increase the crosstalk, increase the significance of the proximal lesion. This is a big concern. Say you have an LED lesion and a left main lesion, and it looks like the mid-LED lesion is the most significant. You fix that, and then all of a sudden the left main lesion becomes significant. That's a big deal because that patient should have gone to CABG, and instead you've put it in a stent in the LAD. So the goal, my hope actually was that the resting flow would be better, but then I have cases like this where this patient has relatively diffuse disease across the proximal to mid-LAD, as well as a distal lesion beyond that first diagonal. You can tell that's relatively diffuse. You pull back the RFR curve, and you see that it's relatively diffuse, but by putting a long stent across the proximal third, I could get rid of the prediction was that I was going to increase the RFR by 0.15 by putting a long stent in. So I put in this long stent after shock waving it, et cetera, and I think, well, that's going to resolve the problem. Well, then all of a sudden that distal lesion becomes positive at 0.79, and then and only then after I fix the distal lesion, then the RFR becomes 0.95. These are nightmare scenarios, right? You think that it's going to work out, and it doesn't. And so we have issues with the prediction model. And this was shown just recently last month in JACC Interventions that both FFR and IFR, even though IFR has a smaller error, a 4% error in the value, FFR has a 12% error in the post-PCI prediction. In terms of actual classification error, it was still roughly about the same. 1/3 of the time, both IFR and FFR it became either significant or non-significant. It still was misclassified afterwards. So I think of it as in cases of diffuse disease, you have to be more cautious. It's not going to be as clear that the post-PCI physiology will be accurate in the setting of diffuse disease. So finally, of course, we have to deal with areas of cases of discordance. IFR and FFR will differ in 80% of cases. In this extreme example, a osteal PDA lesion is 1.0, completely normal by IFR, but completely positive after just a little bit of IC adenosine, 0.72. So what do you do in these cases? Well, it depends on how easy it is, whether the patient's symptomatic, but sure enough, I want to stent this. I stent it, and the post-PCI FFR is normalized to 0.95. So why does this happen? Focal lesions are more likely to have a positive FFR and IFR being negative, as opposed to diffuse disease, which tends to have IFR being positive with FFR being negative. This is because the separation coefficient is larger for focal disease, and when you have a larger increase in hyperemia with the focal lesions. This would honestly, suggest that FFR may be better in identifying the focal lesions that we want to stent, and whereas IFR may be more accurate in defining diffuse disease. Either way, though, a pressure pullback curve will give you more of a sense of that focality versus diffuseness. This was confirmed, this concept was found by Warasara 6 years ago and was recently confirmed just last month in another study by Revraya, which showed that that FFR was more likely to identify focal disease and IFR was more likely to identify diffuse disease, as defined by a pressure pullback gradient number of less than 0.75. So, in summary, the key pitfalls in epicardial wire-based physiology are that, you have technical issues, drift, damping, residual hyperemia, pharmacologic issues with adenosine resistance and caffeine, and then physiologic issues, diffuse and multifocal disease, and discordance. Measuring FFR and NHPR should be made as simple as possible, but not simpler. Thank you very much.
Great, thank you, Arnold. We just have a couple minutes. We have 15 minutes per talk and discussion, so we have a couple minutes for questions. If you have one, again, please raise your hand and we'll get you a mic. That was a great talk, Arnold, and love the tips and tricks. I would mention, we've had the same issue with the end-stage kidney disease patients, and I think hemodialysis and fistulas is my theory for why the IV adenosine isn't working, and so we'll go to IC. We've also seen that with liver patients who have shunting of blood, but I think we have a question. Go ahead.
Yeah, just a quick one. For the IFR, the initial drop that we see, which kind of normalizes, what's the mechanistic explanation for that? And I have seen in my lab, there have been operators who have used that number and proceeded with a stent, which makes me upset, and it happens quite often. And if you use the contrast IFR, that initial drop kind of lingers on longer.
It's residual hyperemia from the contrast, which causes 60% of the hyperemia of adenosine. And that lasts for 30 seconds.
So the RFR is physiologically depicting an increased hyperemic response.
Right. if I understand you correctly, the mechanism of IFR being positive still for 30 seconds is that you still have contrast effects on increased flow. It's supposed to be a resting flow, and you actually have faster flow than that because the contrast hyperemia.
I was wondering, first of all, are people still doing wire-based physiology? And then second of all, are people still using hyperemia or doing just resting or doing a hybrid effect? I don't know. Chadi, do you want to make a comment about that?
We're restricted by whatever the hospital give us, so at least at this point we don't have, the only thing we have now is like either Boston or the Philips system wire-based. I usually go IFR or DFR, that's what we have. I can't remember, like 3-4 years since last time we did adenosine, so it's been a while.
And just a quick comment, from simple, what I do, Arnold, is I do PDPA, IFR, and contrast FFR, and that takes about 15 seconds, and now you have 3 numbers if they're all wrong, if they're all right, all severe, if it's all severe, you're true. If they're not, it's only if they're discordant that you need. And here's the issue: who can tolerate 5 minutes of adenosine? Like literally. And the second question I have: when do you have hyperemia with adenosine? What do you use as your number?
I mean, it's supposed to be 2 to 3 minutes, right? So if it's central line, that's 30 seconds to a minute, and then if it's peripheral IV, depending on how far it is, it could be 3 minutes.
Yeah, see, I asked that question because I don't think there's an answer to this. You don't know when you have hyperemia with adenosine. So when we do all the coronary physiology tests that you're going to hear from later from Olga and Bill, how do you know? And you get so many hemodynamic changes. Your blood pressure goes down or goes up. Your heart rate goes faster. So when do you really know? And so what I do with CoreFlow, I actually I do repeat measures, and then when I get the lowest one, I know. But I think it's a big issue with IV adenosine, in contrast to IC.
Thank you very much. So in the interest of time, I apologize. I ran over because I looked at the clock and thought that was all my time. So their next talk is Yader Sandoval talking about pressure pullback gradient, when and how. Here's the clicker.
Thank you, guys. Great session and great to see a packed room in the morning. I would just add that it used to be that you needed to have a physiology guru in your lab or in the region. This field has changed rapidly in the past few years with now facile methods to measure physiology from CT, from angiogram, from wires. And now, to be honest, it's going to be impossible to ignore how you can easily quantify physiology from pretty much a number of modalities. So it is pretty much upon all of us to understand how to look at this data. I've been asked to talk about PPG, something that you might have or might have not heard. I work with a number of companies in this field. Tim was just alluding to this, right? I think it takes less than 30 seconds to do a quick assessment, right? You say, you start here, let's do a PDPA, let's do a non-hyperemic pressure ratio, and let's do FFR. But I would invite all of you to think that we have historically thought about this in a binary fashion. We all recognize that this is a continuous variable, but we've really thought about it almost like as a pregnancy test, right? Is it abnormal or normal? Is it below a 0.8 or not, right? And what that causes is that we think about coronary artery disease as a unique phenotype and has created problems. If we think about our field, and we need to be humble about our field, we have this quote-unquote negative trials in coronary artery disease, courage, ischemia. But part of the problem is that we have encapsulated all of the patients with the same phenotype of coronary artery disease, whether they have focal, diffuse, or mixed coronary artery disease, into the same bucket. And therefore, we shouldn't be surprised, to be honest, that we are trying to treat all the same patients with the same therapy, and maybe we're not doing our best job in patient selection. Same thing, if we're humble about our field, we do all these great PCIs, we have this great, excellent, all of our reports say excellent angiographic result, but if we think about it, a quarter of our patients will have a suboptimal physiology in routine clinical practice after quote-unquote optimal PCI. This has been reported with non-hyperemic pressure ratio, with FFR, in a number of studies. No matter how good we think we might be, this is the reality. A quarter of our patients have a suboptimal physiology. And a lot of it comes to this issue of phenotyping, of really better understanding the pattern of coronary artery disease. This is from CT, but I think it elegantly illustrates the concept. You can see both of these cases have the same distal FFR. It is 0.64 on the left, 0.64 on the right. But now, once you do a pullback, you can understand that the case on the left is one that has a huge delta. It's focal coronary artery disease. These are the patients that likely will arguably benefit from PCI, whereas the case on the right has this decay on FFR diffusely across the vessel. This is maybe the patient that needs medical therapy, maybe something else, but it's probably not the one that PCI will provide an improving maybe MACE or symptoms. And the problem is that these patients as a whole have been in the same sort of like trials. So we need to move beyond FFR, right? We need to move to phenotyping on the left focal coronary artery disease with a huge step up, diffuse with a gradual decay. So what do we expect? This has been published, but just to illustrate it, in these curves from this paper published in 2024, if you look at the left, if you have focal coronary artery disease, you're going to have a significant gain in your post-PCI FFR. Those are the patients that we know they do very well with improvement in symptoms and likely also improvement in their outcomes. Whereas when we have diffuse coronary artery disease, there's now this, gradual, increase in pressure gradient across your pullback. These are the patients that end up with a suboptimal physiology after PCI. Now, how many of you do a pullback in your routine clinical practice? I would argue that probably not many of us have done this historically all the time. It takes time, it has been cumbersome, there's been a number of barriers, but it's making a comeback, and that's what we're talking about here today. And it's making a comeback because it gives us a better ability to understand these phenotypes, and now, again, across multiple modalities, it is easy to quantify. I'm showing here for wire, for functional coronary angiography, and from CT. When we see these curves, the reason you may say, well, I've done this all the time, I don't need a number. The problem is that when you look at all these curves, there are some that are obvious that you may think maybe there's a focal disease, but there are some that if I ask the panel and experts, we may disagree potentially on whether that's focal or diffuse or mixed coronary artery disease. And the question is there a better opportunity for us to objectively define these phenotypes for pretty much help with management. So this is what led to the concept of PPG, pullback pressure gradient. You might be hearing more of this. This is the landmark publication by Carlos Coletti and Jack now a few years ago, in which they were able to pretty much take the relationship between the length of functional disease and the maximal FFR gradient across the FFR pullback on the vessel, and pretty much put that into the equation that now allows you to give you one number that will go from 0 to 1, with the higher it is, the more focal the coronary artery disease, the lower it is, the more diffuse coronary artery disease. I think we can all agree that there's a number of cases that it's pretty obvious, but there's a number of in the gray zone where this will help us now objectively understand what phenotype they have. This has now been incorporated into the core Aventis software and looked at a number of research studies. And as you can see there, now those same curves that I just showed you a minute ago, now you can get a computed pressure pullback gradient to understand the phenotype of coronary artery disease. And as you can see in red, you can see now the gradients of FFR across the vessel, but you can get now a number that in addition to your FFR in all these examples, you get a PPG value that tells you, yes, there's significant functional coronary artery disease, but in addition, you can inform, is this pretty much focal or diffuse coronary artery disease? What have we learned so far? Well, what we have learned is that this not only helps with physiology pattern recognition, but there's now, imaging correlation from atherosclerosis that helps us understand that probably the reason maybe revascularization may be better for focal coronary artery disease is because these are patients that have more lipid-rich plaque, more thin cap fibroatheroma, whereas patients that have the low PPG are mostly with diffuse coronary artery disease with more diffuse coronary calcium. There's a number of studies that have looked at this, but again, in general, focal coronary artery disease, as shown here, just has more high-risk plaque features, whether that's plaque rupture, thin cap fibroadenoma, plaque burden. So now you can see how we're moving from physiology, but tying physiology to plaque. Why this is relevant at a clinical aspect, from a clinical perspective, it has an implication. As you can see here, and I know, of course, Tim maybe can add on this, since he does a lot of work on refractory angina and patients that we see that have persistent symptoms after their PCI. As you can see here, if you have focal coronary artery disease, there's a high proportion of patients that will be angina-free, whereas when you have a low PPG, when you have this diffuse coronary artery disease, now it's pretty much a toss coin when we do on those PCI patients. A lot of them will have residual coronary artery disease, and it's because of the pattern of coronary artery disease. So it's important, A, from symptoms. Now, what about outcomes? This is the PPG Global Registry. There were a number of centers that enrolled here in the US for this registry. This is not yet clinically available in clinical practice, but PPG is showing in this global registry that now for outcomes, in patients that undergo PCI, they have more target vessel failure, more procedural myocardial infarction, particularly in those that have diffuse coronary artery disease. We shouldn't be surprised. They have longer stents, more complex procedures. So you can see it's not only an issue about symptoms, but it's an issue about outcomes. Now, PPG can help you predict now, based on everything that I just mentioned, what is the likelihood that you're going to have there for a good post-PCI FFR. So therefore, this helps for symptoms, patient selections, and for you to have additional information as to whether you can do better. This was just actually coincidentally, just earlier this year, this is now available in Europe, not yet available in the US, but you will likely be hearing more about this new metric in which you have the FFR, and this is now the platform that is available in Europe. If some of you are from there, you might have potentially already done this. We have not yet done it in clinical practice, but as you can see now, you get a PPG computed to help inform the phenotype. Briefly, since I'm just going a little bit here over time, I'm just gonna say that I think there is this sort of like return of FFR for many of the reasons that were alluded, because now we're pretty much doing it across modalities, right? For CT, pressure microcatheters, functional angiography, even now image-based modalities that can compute and derive FFR. So it's making a little bit of comeback, and it goes beyond the discordance that all these things are complementary. I do want to mention, because this question might come up, there was just published literally a couple of weeks ago, now the PPG concept in resting conditions in Euro intervention. So for those of you that feel strong that this needs to be done with a non-hyperemic pressure ratio, there's data suggesting that the concept can still be derived in resting conditions. So I would just conclude that it's important for us to move beyond the traditional binary approach of thinking about an FFR abnormal, yes or no, but thinking about the phenotype of coronary artery disease because it impacts symptoms and outcomes. And be aware, I'm going to highlight my point number 4 here, that there will be a randomized trial likely in the near future called PPG Primetime that will further explore this in a randomized fashion. Thank you so much.
Thanks, Yader. Great talk. Can you talk to us a little bit about the practical aspects? Like, where do you start with your wire, and how fast is your pullback? Do you have to do it, and can you do it manually? And then also, what cutoff do you use? And if it's less than that cutoff, meaning diffuse disease, what do you do?
It's a great question. It relates a little bit also to Arnold's talk. Frankly, a lot of us, I think in the audience and in the US, including myself, we were doing a lot of non-hyperemic pressure ratios. You were doing FFR all the time, but a lot of us had done a lot of non-hyperemic pressure ratios. And I think because of many of the reasons that has been alluded in the past couple of talks, I think many of us have been doing a lot of FFR right now and trying to understand now the pattern of coronary disease. So how do we implement it? Practically 2 things. One is, I really like a body wire, right? If I'm gonna do a pullback and I'm gonna sacrifice my position across the stenosis, I don't like to do that. So I'm gonna use a body wire which helps me disengage the guide, 1. And 2, if I'm not gonna do a pullback, I do the pullback, but I leave the wire in place, and then I'm just pulling the pressure wire so I never sacrifice my position. Now, the other thing that we've done, and Tim can expand to this, is, Bob Wilson did this at the university, and I think, as you've seen, we've done it. I'm sure I can get some criticism about it, is that we've shifted to do a lot of papaverine. So by doing papaverine in the cath lab, it has a less than 1% risk of ventricular dysrhythmias, but, I think it's been established better now what the doses are, 8 milligrams for the right, 12 milligrams for the left. We've had a very favorable experience that by using papaverine, we can get pullbacks in a rapid fashion without the need for infusion, and it's really facilitated the implementation of pullbacks in a routine clinical practice.
Great. Stefan.
Hey, I just have a comment that, to me, PPG I think came out to turn into a number that could be used for research, because it's like comparing horses and zebras. and saying you just have to count the number of stripes. The more stripes you have, it's going to be most likely a zebra. But of course, I mean, you look, there's a zebra and there's a horse. I mean, you can say you don't have to count the number of stripes. So here it's exactly counting the number of stripes, but you actually could see it, how it is and where it bumps up. So the thing is that we still don't have it in the US, but I'm still questioning what's going to be the real incremental value of having that number to sort of guide my therapy, where I actually need to see where it is, where those jump are when I'm doing the pullback. So I just want to hear what you're thinking about this.
Yeah, if you guys haven't heard the stories, our friends, colleagues in Belgium and Als, Bernard de Bruijn, Jerome Carlos were the ones who really came with the idea to compute this value. And if you hear the story from them about how they came with this, reportedly they claim that this was during a live case. They were doing a live case, they did a pullback, and one of the operators, I think it was Carlos, said this is, I can't remember, let's say focal. And literally the other guy who does a lot of physiology next to him, no, this is a diffuse disease. And they got into a debate about the pullback in the same live case about whether this was focal, diffuse, or mix. So it was made clear to them that yes, I agree with you, this is red and this is blue, but in between there's a bunch of patients that they don't agree, and even at their level of expertise, they were like having this debate in the middle of the live case, and they said like, oh my God, we need to have an objective and not a subjective method to help us with patient selection. Frankly, I mean, right now this is with a wire method, but I think now, as I said, physiology is having a transformative period in which now it can be computed easily in a number of ways. This will be a way that I think now, from a number of technologies, will allow us to better understand the phenotype of coronary disease and patient selection. And sometimes it doesn't matter. It doesn't mean that we're going to do PCI, but you can set expectations. You can tell your patient, hey, you have very diffuse coronary disease. We can do some PCI to maybe remove some of the pressure gradient, but there's still a lot of diffuse disease, and your post-PCI FFR may not be up to one. To be honest, maybe we can discuss about that maybe over time, but the question is not focal. The question is what to do about diffuse coronary artery disease, the low PPG. There's some people that feel that maybe DCBs, other people feel maybe, a medical therapy, other people need strombod bypass. I'm sure you deal with it all the time in CTOs, but yeah.
Yeah, I just wanted to add, as a defined PCI investigator, and we really struggled on how to define diffuse versus focal disease, and we really couldn't come up with something. So I think having a number is helpful for studies. And then, it still describes a continuum, the true continuum of disease out there, but you don't have to have a cutoff necessarily, but it helps to describe it better so that we don't have these types of debates.
One real quick comment. Excellent talk, Yader, but one other thing to take into account is when in terms of patients who have recurrent angina, this is only taking into account epicardial disease. And the significant number of these patients are going to have microvascular disease too. So you may have a completely normal pullback FF, right, might be excellent. You still might have post-procedure angina because you have microvascular disease.
Okay, I think we need to move on. It looks like someone's already moved. Oh, there we go, great. So yeah, I think Karim Al-Azizi will give the next talk on when and where to use angiographic FFR. So we'll move away from the wire to the angiogram. Back to the angiogram.
Good morning, everyone. Again, thanks to CVI for having me. Thanks to the great panelists and great discussion this morning. So I'll be talking about when and where to use angiographic FFR. These are my disclosures. So obviously, within the session of physiology, we understand that really angiography has a lot of limitations, and that's why we had to think about other technologies, other modalities to assess pressure loss within a vessel. And obviously, we've been talking about wire-based physiology, and it requires to measure pressure across lesions and in a vessel. And that's because that one view may look narrow, the other view may not look so narrow, and that has always been the dilemma of angiography. So an 82-year-old with multi-vessel coronary artery disease, persistent angina despite medical therapy, and some comorbidities was referred for physiology and imaging guided PCI. This is the angiogram, and all you can see is calcium, some tortuosity, and a bunch of lumps and bumps and moderate disease that you can see in the LAD and the circumflex. And you're trying to find out what's causing the angina for this patient. multiple areas at question. And so the question becomes, if we are looking to relieve angina for these patients, then which vessel really will make the best result and potentially relieve the angina for this patient? So a lot of questions. Symptoms, this angiogram, what to treat, how to treat it, and obviously how to limit contrast. So reflecting a little bit, I don't want to repeat a lot of what Yader and everyone said, but just reflecting on the history of angioplasty, this is the New England Journal of Medicine publication by Grunsick back in '79, doing an angioplasty. And essentially, it was involving measuring pressure loss gradient across a lesion. So physiology is not really a new thing. This is really a concept of understanding that we want to relieve the pressure loss that is seen within a vessel. Multiple trials over time have come out with FFR, including DEFER, FAME, and FAME2, and I don't want to elaborate any further, but obviously determining or showing that it is safe to defer once you hit a certain number or above, so greater than 0.8, and that's really the benefit or the power of physiology, to defer safely and not at the cost of having an MI or potentially having issues. Fast forward, we've gone into the SYNTAX-2 trial, where basically it was a follow-up to the SYNTAX-1, which compared PCI to CABG, and we've all known the results of the SYNTAX-1, that when you have complex disease, CABG obviously is better than PCI. But this was actually one of the earlier trials in comparing both arms, but potentially actually doing a more contemporary PCI involving physiology and imaging. In 98% of the patients had physiologic assessment, and about half of them were downgraded from 3-vessel angiographic disease to about 2-vessel or single vessel. So this is the front-end benefit of physiology in really assessing those patients when they come into the cath lab. So when patients come into the cath lab with 2- and 3-vessel disease, the question becomes, do you really need to send them all to CABG? Did we do fine work in assessing them and understanding their disease? Well, in SYNTAX-2, we've learned that half of them were downgraded, and if we built the revascularization plan of PCI based on this, those patients did much better as compared to the original angiographic PCI arm of SYNTAX-1 out to 5 years, and is seen here. And in even an anecdotal kind of discussion / analysis, which is, obviously has a lot of caveats, comparing the SYNTAX-1 CABG to SYNTAX-2, they were very similar in terms of outcomes out to 730, basically long-term outcomes. But obviously has a lot of caveats, but it's an eye-opener to tell us that PCI is not always the best thing. PCI is replacing the atherosclerotic disease with a different kind of disease and hoping that we have relieved that pressure loss and potentially relieved angina. So what about the role of physiology in post-PCI? So we've talked about we've talked about giving us the green light, red light, but perhaps how about the role of physiology in post-PCI? Yader has shown the work of defined PCI. We were part of this study, showing that 1 in 4 patients left the lab with an abnormal value. And how did that translate to outcomes? Well, sure enough, if you scored a number less than 0.95 on the IFR scale, you had events. So it's not even the cutoffs that we are used to. It's about leaving gradients in pressure loss within the vessel after you intervene. How did that relate to symptoms? Well, if you had more diffuse disease, you do a PCI, it looks great angiographically, but if you do a post-PCI and you still have depressed FFR values or pressure loss within the vessel, you're likely to still have angina, which is something to think about as well. How about relating transstent gradients or gradients within the stent and beyond pre and post stent? How does that relate to outcomes? Well, it does have hard outcomes, as seen by the work by Barry Uretsky. Having gradients within the stent itself, or even scoring an FFR value that is less than 0.84, was linked to worse outcomes on the long term. So there is benefit and utilization of physiology in post-PCI settings. So the question is, how can you assess multi-vessel, look at difficult disease like calcified tortuous vessels, understand the pattern of disease between focal and diffuse, recognize the areas of pressure loss within the vessel so that you can plan the PCI, perform a post-PCI physiologic assessment, and also be efficient and not just do 2 cases a day, right? I mean, you're trying to be efficient, and nowadays these cath labs are very busy. You're trying to treat those patients efficiently, but also try to get the best outcomes of those patients. So thinking beyond the wire, the limitations of wire-based technology is there is risk, there is time, there is additional cost. There has been now several devices or softwares that have come out, the FFR Angio, QFR, and others that are looking in ways in assessing pressure loss across the vessel without having to put a wire down. For example, the CathWorks FFR Angio system requires 3 angiograms, 30 degrees apart. So we are going back to the angiogram without having to use a wire. And this is the workflow of the system. It classifies your angles. It detects the vessels accordingly. You detect the lesion at question. And subsequently, a map comes out that will tell you exactly, based on the optimal frames that you have chosen, and the system honestly chooses it for you. It's gone better and better over time. It will detect and will show you the lesion at question. So is there some data to support a technology like this? This is a table that compares 3 different technologies, and what we found is that the diagnostic performance compared to the wire-based FFR for CathWorks has the highest as compared to MEDIS. MEDIS had some good comparatives as well to the FFR wire. And with some clinical outcome study that was done in Japan, we were able to see that actually the safety of deferring based on this software was pretty good in general and compared to the revascularization arm, which we tend to see more events. More data came out from the provision study, again comparing these 2 arms, looking at an endpoint of non-inferiority of revascularization rate of FFR compared to wire-based FFR. And what we found was basically it was very similar. But is that enough to basically put this across the whole board, to actually apply this as your standard of care? Well, more data is coming out because there has been questions about whether all these systems are equal, all these systems are the same and should be managed the same way or treated or assessed the same way. And in this analysis, we found that 4 softwares looked at a certain vessel or lesion, and they had some disagreements between the values that were obtained from the analysis. Although the caveat here is that CathWorks FFR Angio was not in this analysis. More importantly, and more recently here, Favor 3 Europe that assessed QFR did not reach the non-inferiority point with a lot of caveats within the study. So it gave us definitely a stop and a question mark on whether all these technologies should be assessed the same way, should be looked at the same way, or should we wait more? That will take us to, well, maybe we need more data. So the Alraies study was just concluded in January. We enrolled in this study basically comparing wire-based technology versus the CathWorks FFR Angio based on cutoff values of 0.8 in deferring or doing PCI, and the wire-based arm involved non-hyperemic pressure ratios and FFR, and the 1-year assessment looking at non-inferiority in MACE, and about 2,000 patients across 60 sites. We're hoping to see the results of this study soon. So what is the proposed algorithm in involving this kind of technology in a contemporary cath lab? Well, this is a great kind of outlook that was actually published by Eskened and colleagues in neurointervention, where if you really integrate this kind of system within your workflow, it has a place, and it doesn't really necessarily need to replace the wire-based technology, but perhaps actually can work in complementary to the wire-based technology in a way where you can assess a vessel while you're actually treating another vessel, and this way you can be efficient with doing that. You can use the technology itself to actually do post-PCI physiology after you're done without having to put the wire back down. So there are roles of this angiographic or functional angiography, which is really the overarching name of these technologies that we use in the field. There are several reasons why you can have pressure loss, and we've seen the adverse events or the adverse outcomes of patients that may continue to have pressure loss despite a good PCI. And so more and more is yet to come on this, but is it an easy way to rule out, to tell us that you've done a good PCI? We continue to learn through this. So back to the case, this is the patient that we assessed. We've obviously taken our 3 angiograms. This is using the CathWorks FFR Angio system. We've assessed the LAD, which appeared to be the tightest, and actually it was 0.95, and so it was safe to defer in this case. We've done an assessment also on the RCA, and it was had some moderate disease as well, and it was 0.82, so we felt we would defer as well. We assessed the circumflex, and it was the most significant out of all the 3 vessels we've treated that lesion as well with imaging guidance, and subsequently a post-PCI assessment can be done very easily for these patients, just repeating a couple of angiograms and even using a previous angiogram, and getting a post-PCI physiology at here where a delta change went from 0.77 to 0.96 made a difference, and hence, the patient's angina was relieved. So, in conclusion, the use of physiology in the cath lab is important for qualifying lesions and understanding the potential impact of PCI on vessel hemodynamics. Wire-based physiology continues to be the most validated, really in assessing intermediate stenosis with strong outcomes data over the years that have come out. Functional angiography provides a fast, efficient, less invasive way, and you can assess truly 3 vessels without having to wire all 3 vessels essentially to assess it when you have clear clinical conundrums. Wireless physiology, or what we call functional angiography, softwares continue to develop, and there are some conflicting data, but outcomes data is what matters at the end of the day, and we look forward to the results of the Alraies study. I do believe personally that both wire-based physiology and functional angiography will have a place in every lab, will have a place in the algorithm of assessing those patients, just like CT-FFR or physiology done on CT that can be as simple as gatekeepers before you start intervening. Thank you all for your attention.
Thank you, Karim. Great talk. Can you talk a little bit about how you actually do the workflow? For example, do you have a tech who's a super user who does the analysis, or do you unscrub and do it, or a fellow? And also, how automated is it, and how much time does it actually take you?
Yeah. No, thank you, Bill. We started initially, just like with any technology that we bring in the cath lab, is we try to train 2 or 3 super users so that they really get to know the ins and outs of things. And then eventually with utilization and usage, it kind of spread to the rest of the techs and the nurses, and everyone has become very familiar with it. It's like essentially putting a new app on your phone. It takes a few times till you get used to it. I don't have to scrub out. What we have learned to improve our efficiency in making that decision is that once you see moderate disease in general in the cath lab, whether it's wire or wireless, we make that decision very early. Instead of taking too many pictures, go ahead and run the analysis. So we ask for the card, you hit, already the tech is working on running an analysis, pulling the angiogram. So by the time, for example, you're shooting the RCA, they're already finished the analysis of the LED and circumflex. So from an efficiency perspective, you definitely can improve once the decision is made to jump to make an analysis for the patient. But back to the training piece of training techs and nurses, I think the system has gotten more and more self-automated, very easy to use. The direction is there. It takes you step by step. And more importantly, what you take back to your referrals or take back to the physicians or the heart team is that actually that report is being sent as a PDF report in the PACS system at the end of your cath film. So after you have your radiation analysis, you have a PDF report of that analysis essentially.
Yeah, I agree completely in that we're doing it the same way, and just to let people know, as Karim showed you, basically you put a little plus sign on the lesion in the 3 different views, and it's really key it reminds us to do a good angiogram. Yes. With minimized panning, making sure you really lay out the vessels well. And as long as you do that, then the system automatically traces. We try not to adjust it at all unless there's an egregious error, which usually there isn't. And then within a minute after that, you have your answer. So it is very quick. And also the nice thing is the serial lesions or virtual PCI. You can do all that very quickly and get an assessment after fixing one lesion. And so I think as we get more data, it'll really help make it more efficient in the cath lab.
Yeah, I love the wire, but even I will confess, if you can do it replaces pullback on all 3 vessels. It allows you to do a pullback without having to put the wire back in. It allows you to do post-PCI physiology. I think it's going to have a very strong role in the cath lab. We're going to move on to microvascular dysfunction. So our next talk is Olga Toleva on how to assess for coronary spasm.
Good morning, everyone. So we're going to move from the obstructed vessels to the ones that actually are open but still cause problems. First of all, I'd like to thank for the invitation to this morning's session. These are my disclosures. What is coronary vasospasm? I think this was something that really intrigued me as a medical student. I couldn't understand how someone could present with ST segment elevation, severe chest pain, and then they go to the cath lab and the arteries look normal. Well, this is Prince Metal's angina. Usually presents as a resting angina. Sometimes patients could also have exercise-induced or cold-induced spasm, which could cause angina. We know that cocaine users and smokers could sometimes come in and have spasm in their arteries, as well as sometimes after we manipulate the vessel with either a stent or a wire, we could see spasm in the distal portions. Coronary spasm can only be documented as a dynamic lumen narrowing on a coronary angiogram. The rest is ECG changes and chest pain, but really the hallmark of the diagnosis is in the cath lab. We sometimes could see it spontaneously. Sometimes when we engage with the catheter, we could see that the vessel spasms. But the most important way how we make the diagnosis is with coronary function testing, when we bring the patient to the cath lab and provoke with acetylcholine. There are a few things that we could see on an angiogram, and usually the epicardial spasm is pretty obvious. It's a dynamic narrowing of the vessel, but sometimes as we provoke with acetylcholine, we could see the ECG changes and the chest pain, but the vessels only on the microvasculature level could spasm, so we assume that this is the reason for the problem. Acetylcholine is the main medication that we use in the cath lab to provoke spasm and make the diagnosis. In a normal artery, it actually vasodilates, but if we have endothelial dysfunction or reduced production of nitric oxide, the acetylcholine directly affects the smooth muscle cells of the vessel, and they actually constrict, which we could document on an angiogram. Ergonovin also works, but via different mechanisms, and in most cath labs, we don't use this anymore. Acetylcholine mechanisms of action are multiple, and I'm not going to go and spend too much detail on it, but it could affect the endothelial pathway, and this is how we know that the endothelium is abnormal and is causing a paradoxical vasospasm when the patient is tested in the cath lab. It could also directly affect the smooth muscle cells, and when we see a transient constriction of more than 90%, we make the diagnosis of vasospasm in the coronary function testing. We've published this several years ago now, 2 years, but this workflow shows you that acetylcholine is testing the endothelial-dependent pathway, and if we give a high dose of acetylcholine and see severe, more than 90% spasm, we make the diagnosis. If we see a narrowing in between 0 to 90%, we call this endothelial dysfunction, and if we don't see any narrowing, but we see typical changes, this is the diagnosis of microvascular spasm. This is a busy slide, but it's a summary of all the different protocols that we could use of how we apply acetylcholine. In the cath lab, it could be given intracoronary via infusion. This infusion could be given directly through the guide catheter, or it could be given through a microcatheter selectively into the LAD. There are more popular options nowadays where we use a hand injection with an intracoronary slow bolus with different dosages, and these are the different concentrations if we decide to use infusion or manual injection. In summary, we start with a low dose of acetylcholine. First is a test dose, which usually is between 2 to 20 micrograms, and this dose also triggers the endothelial function of the vessel and helps us understand how the coronary blood flow changes based on abnormalities on endothelial level. And then we go to a high dose, which is usually the 100 micrograms dose, which is the dose that traditionally provokes spasm. If we see the spasm, then we make the diagnosis. If the 100 micrograms doesn't work, sometimes in male patients, we could use 200 to confirm that the patient is vasospastic or not. And if we don't see anything, but the patient has symptoms, we make a diagnosis of microvascular spasm. This slide I prepared of how I do it with the Coroventis system and dual lumen microcatheter, which I attach to the pressure wire. And I intermittently advanced this microcatheter to the ostium of the LAD, where I infused through a high-pressure pump. This is the pump I use. It's a flow lamp pump, which is attached with fine tubing at the end of the microcatheter, and this allows for very slow injection, which is very safe. This is the other way of how we could attach directly to the guiding catheter of the manifold and use for infusion. I think Tim uses this and the Mayo Clinic as well. So what is the safety of acetylcholine? This meta-analysis published by the Microvascular Network and evaluated more than 16 studies with different protocols showed that acetylcholine is safe and it has only less than 0.5% of serious complications and 0 deaths. There was no difference in the incidence of spasm based on the different protocols used. So how does coronary spasm present? It could be presenting as a stable angina or myocardial infarction with non-obstructive arteries. We also know that if we need to do it in ANOCA patients, it's safe and performed even after within 48 hours of the presentation of the patient, as demonstrated by this Italian study. And here is a case. This is a 53-year-old lady who presented with non-STEMI, deep T-wave inversions in the precordial leads, chest pain, and was brought to the cath lab where her coronary angiogram showed not impressive coronary obstruction. There was no clear culprit identified. Arteries look pretty normal. No intravascular imaging was done. However, the LV-gram suggested some apical dyskinesia or akinesia and normal right coronary artery. After the MRI was performed, we were still puzzled with the diagnosis. Is it Takotsubo? Is it microvascular dysfunction? Is it spasm? In my practice, I wait 1 to 2 months before I do coronary function testing for these patients. So I brought her back to the cath lab, and after we held the medications for 48 hours, look at what we saw. And we were like, oh my God, did we miss a lesion last time? This is exactly where the culprit should have been. So after a while of giving several doses of nitroglycerin and nitroprusside, the artery actually opened and there was no lesion anymore. And we've seen some of these with STEMI patients, so remember to give nitroglycerin when patients present. Intravascular imaging showed no significant atherosclerosis. The patient was successfully treated with calcium channel blockers and is angina-free. Another example of an elderly patient who came in with angina, some non-obstructive coronary artery disease. We brought them to the lab for a coronary function testing, and you could see some diffuse atherosclerosis and a mild bridge at the proximal segment. Diagonal RFR was negative. We then started with acetylcholine at test dose, 2 micrograms, some chest pain with that. At 20 micrograms, you could see the bridge pronounced, not much of spasm, and then when we gave 100 micrograms, this is what we found. Severe coronary vasospasm, which concluded the diagnosis of Prince metals, which was successfully abolished with nitroglycerin. Also a note that microvascular dysfunction, coronary vasospasm and bridges could coexist, so it's always important to do a full comprehensive analysis of these patients. So in conclusion, spasm can occur spontaneously and can be documented on an angiogram. The gold standard is coronary function testing with acetylcholine provocation. Endovascular imaging is a very important part of the evaluation of these patients to detect atherosclerosis or myocardial bridge. And acetylcholine tests the endothelial-dependent pathway. It is safe, and don't be afraid to use it in your cath lab. Thank you.
We have to hear from other folks on the panel. Manoj, are you having any challenges evaluating for microvascular dysfunction or spasm?
Yeah, certainly. We want to remember with these patients that when we see that they have no obstructive coronary arteries, that when they have coronary vasospasm or other endotypes of microvascular disease, that they're at higher risk for adverse outcomes. So I think it's really important to take these extra steps to be able to define whether a patient has coronary spasm as their endotype of microvascular disease. I think oftentimes when we do this testing, I have challenges about whether I'm seeing the degree of decrease in diameter that is really clinically meaningful, and I find that challenging at times. So I asked the panel and wonder, in your experience, do you find that you need to have reproduction of symptoms at the time that you do the testing to really cinch the diagnosis? I feel like a lot of history taking is also essential here to really establish the diagnosis, which can be challenging.
Well, I'll start with that. I think classically it's chest pain, EKG changes in greater than 90%, but in reality that's not what it always happens. And we do infusion is the WISE protocol, so we do an infusion over 2.5 minutes. And frequently I'll have LADs that are completely closed and no EKG changes or minimal chest pain, and obviously that's severe spasm. So I think you have to be a little flexible with that. Another thing I would say with this, first of all, excellent talk, Olga. And this is a really common problem. 2 points I'd like to make out. There was a survey they just done of people doing coronary reactivity testing, and 50% of them were not using ACH. And I'd really implore people, if you're going to get into this business and you're going to check people for microvascular and spasm, you have to use ACH. Because if you don't, you have an incomplete diagnosis, and an incomplete diagnosis or wrong diagnosis is worse than no diagnosis. So number one, learn how to use it and know how to use it. Second, in coronaries, when not coronary function testing, but that you see areas that might be spasm, use intracoronary nitroglycerin. My experience is that lots of people, because they have nitro in the cocktail, are less frequently using IC nitro. And if it's an area that you think you need to give IC nitro.
Any comments here?
Not to top what he says, no. Yeah, exactly. I guess I'm going to ask after this, I want to know from the panel, who do you want us to send for all this, and how are you choosing the right people to send for microvascular dysfunction? Because we all see chest pain in our clinic, and we think we know what is cardiac and what is not, but I want you to help us get the right people to the lab to get the right diagnosis. So that's the question I'm going to ask after the next talk.
Okay. Should I?
Go for it.
What, should I talk or should I give the answer to that? Okay, yeah. I mean, I think it's incumbent on us to give a diagnosis to our patients. And so I think there are cases where we're expecting epicardial disease and we don't find it, or the physiology is negative. And then I think in all those cases, we should go on and do further assessment. And so, certainly there are cases that come in scheduled for coronary function testing, but I also think we should be doing it more ad hoc personally. Why don't we?
Great talk, Olga. I have a question about myocardial bridging, something that we don't see very uncommonly. And for the significance of it, using adenosine for FFR wouldn't work, yeah, because it's more during systole or causing hyperemia. And people are advocating to use dobutamine to test for that. What do you do, and how do you treat them besides sending them for surgery if you think they are significant?
Well, this is a great question, maybe a topic for next year's symposium. In general, dobutamine provocation is the one we use, reaching 85% of target heart rate and RFR target of less than 0.75. The Stanford group has published a very good review of the correlation between diastolic FFR and RFR. So RFR is a reliable method. Adenosine FFR is unreliable in dobutamine, in myocardial bridging because it's a dynamic obstruction. The other very important component of its testing is an IVUS evaluation of the halo thickness and compression. So for those of you that encounter it during coronary function testing, I think, and I urge you to try to provoke the bridge as well, because a lot of the times bridge coexists with spasm and could be the reason for pain. Unroofing is the final stage of what we can do. There are surgeons that could do it via open sternotomy, but could be done robotically as well.
We're going to move on, but I do want to thank you for helping clarify a number of issues, including the dose of acetylcholine to use and also how much diameter stenosis, spasm you have to identify. So we're going to move on to Bill Fearon, who's going to tell us about how to assess for microvascular dysfunction.
Great, thanks Arnold, and thanks Manoj and the CVI team for the invitation. It's a great meeting and really enjoy being here. So I'm going to talk about how to assess coronary microvascular function. Those are my disclosures. I think the first question is, why do we need to know how to do this? And it's important to realize that the guidelines now recommend it. So the 2021 AHA-ACC chest pain guidelines now give a 2A recommendation for patients with non-obstructive disease, negative physiology, to move on and measure coronary flow reserve, the index of microcirculatory resistance in our patients. The 2024 ESC guidelines upped that to a 1B recommendation. So I think it's really incumbent upon us to start incorporating this into our practice. So how do we do this? There are a number of wire-based techniques or indices that we can measure. I think we're all familiar with fractional flow reserve and the non-hyperemic pressure ratios, IFR, RFR, et cetera. Those are specific for the epicardial vessel. We're going to talk about how to assess the microvasculature, and we have indices that are specific for the microvasculature, like IMR, as well as the hyperemic microvascular resistance, HMR, and the microvascular resistance reserve, which is the newest kid on the block, MRR. CFR is the oldest kid on the block, coronary flow reserve, and it's important to recognize that that actually measures or incorporates the entire coronary tree, both the epicardial vessel and the small vessels. Now, in patients who have quote-unquote normal epicardial vessels, we tend to apply CFR as a assessment of the microvasculature. So how can we do this? Well, Philips has the Doppler wire, which is currently not available, but a new iteration will be coming soon. And that allows us to measure velocity of the blood flow. And we can look at the hyperemic velocity or flow and compare that to the resting flow. And that is the definition of coronary flow reserve. And we can also measure HMR with a Doppler wire. What we're, I think, seeing more commonly used now and where we have the most data is with the bolus thermodilution technique. And the way this works is the Abbott wire, the pressure sensor, has a thermistor near its tip that can measure temperature. And then with the appropriate software, the shaft of the wire can measure or act as a proximal thermistor and measure the time that you inject room temperature saline, and that starts the clock. And then the distal sensor, a thermodilution curve, is created. Now, it's different from a cardiac output measurement, for example, with a Swan-Ganz, in that you're not measuring the area under the curve. You're basically, or the system's not doing that. It's measuring the speed at which the temperature returns to normal. And so for that reason, the amount of saline you give and the actual temperature of the saline doesn't really matter. It's looking at the change in temperature over time. But from that, the upshot is you get a mean transit time, and this is inversely proportional to coronary flow. And so we can calculate coronary flow reserve using that mean transit time at rest compared to hyperemia. We can also calculate IMR, or the index of microcirculatory resistance, and this is based on Ohm's law. And we're looking at the change in pressure across the microvasculature, the distal coronary pressure minus the venous pressure. And we divide that by flow. And as you can see from the equation here, we can simplify it. We generally ignore the venous pressure because it's negligible compared to coronary pressure. And we can correct the equation, and we get IMR as simply the distal pressure times the mean transit time. And we do this during maximal hyperemia. And the reason that's important is because we're measuring the minimum achievable resistance, which we think is a reflection of the health of the microcirculation. It also eliminates the impact of changes in heart rate and blood pressure and other variabilities, making it a very reproducible index. Now, there is a newer technique called continuous thermodilution, which involves using a special microcatheter, the Rayflow microcatheter, and infusing the saline continuously. The advantage of this is that it gives you a very user-independent method, very reproducible. It is a little more unwieldy in that you have to have an infusion pump, you have to have the microcatheter, it takes a little setup time, but it does allow you to measure these indices as well, and there's emerging data with that technique. As far as the bolus thermodilution, that's what I'll focus on. It was validated in an in vitro and animal model, and it was shown that having the wire at least 6 centimeters down the vessel is important. It also found that it's independent, like I said, of the amount and temperature of the injected saline. As long as you use less than 5 cc's, there's no effect on resting flow. The variability of the mean transit time did not differ between either hand or EKG triggered injections, so generally we just do a hand injection. And it's recommended that we do 3 boluses at rest, and then that's averaged, and you do 3 during hyperemia. We did an animal validation a number of years ago where we had a flow probe around the LAD of pigs as our gold standard, and we compared the thermodilution, bolus thermodilution, to that on the left side. You see a very good correlation. We also did Doppler measurements on the right-hand side, and the thermodilution seemed to correlate just as well, if not slightly better. We also just recently published this looking at the bolus technique of IMR versus the continuous technique, also showing that the bolus thermodilution is very reproducible and on 2 repeated measurements. The normal values, less than 25 is considered normal for IMR, but it's also important to remember this is a spectrum, and so there's a gradation, and particularly in some settings like STEMI, higher cutoff values may be applied as far as predicting events. So practically, how is this done in the cath lab? Well, the Corventis CoreFlow system has made it very streamlined and easy to do. You use a wireless Abbott pressure wire, and it connects to this system. Your case preparation is very similar to doing any coronary physiology. You give some nitroglycerin, you anticoagulate, you connect and calibrate your pressure wire outside of the body, you equalize it to the guide catheter. You position it, like I said, at least 6 centimeters, and typically we'll do it in the distal 2/3 of the LAD. You ensure your guide catheter is adequately engaged, and you flush it with saline and allow any effects of contrast to wear off. So this is where we position a wire. This is a 55-year-old man who had a history of coronary disease but was having recurrent angina despite medical therapy. This is how we set it up. We'll have a transducer, or have the manifold with a 3-way stopcock connected to the back and a 3 cc syringe. This will just show you how we, first we flush with saline just to clear the guide catheter, and then you give it a few seconds to settle, and then you press start now for your resting measurements, and you go ahead and do a resting measurement. This gives you an idea of sort of the briskness of the injection that we use. And you see that this is very quick. You know, you do 3 of these at rest, then you give adenosine, and you do 3 more. The blue tracings shown here represent the resting. The average was 1.39 seconds. And then the orange tracings are the hyperemic, and the average was 0.48. So our coronary flow reserve was 1.39 divided by 0.48, or 2.9. Our IMR was 0.48 times 85, 41, which is high. So this patient does meet the criteria for microvascular dysfunction. And the FFR was 0.85. So you get all that measurement at once. Now, one thing that's important is to look at the tracings. So this is a different case that had normal microvascular function. You'll see that the FFR was 0.93, but this very same tracing, you now see an FFR of 0.79. And so what happened? Well, there's a yellow perpendicular line that you can adjust to make sure you're in the right spot, and you don't want to be in an artifact. And occasionally, fortunately rarely, but the system will choose the wrong spot. And so you always want to look at the tracings and not just focus on the numbers. There are other error messages that you can get that'll tell you if you need to re-zero your temperature sensor or make sure your guide's adequately engaged. There was a very nice paper that describes this mnemonic cath CMD, which goes step by step through how to do this, and I encourage you to look at that reference. So in conclusion, like any new technique, it's important to do a number of CMD cases, I think, in a short period of time to become comfortable with the methods, but I think you'll find that assessing coronary microvascular function can now be performed easily and readily in the cath lab. Thanks for your attention.
Thank you very much. We're going to start the discussion with Chadi. Chadi, do you have the Corventis system? Is this enough to motivate everyone to get this? And how do you weigh that against the other systems?
But we don't have that. Unfortunately, I have to refer somebody in Michigan to help us with this. The setup is easy, but we don't have the support from the hospital. And two, the setup of the practice, right? When you have too many groups, I think the funnel of the cases is not steady. So we felt like maybe just sending to somebody who does it all the time would be more accurate and give us more valid data.
Great. For those who have referral centers for microvascular disease, how do you make that financially viable when you're not actually paid any more than a regular FFR?
Yeah. So this is an important question, and we actually just looked at it. So we started it in Cincinnati at Christ 5 years ago, and now we just looked at our thing, and our contribution margin for coronary reactivity testing is the same as for PCI. So the institution is very happy to be supporting us.
Yeah,
And we're happy to help people with that, by the way, if you need to.
I also think it is important to incorporate intracoronary imaging in these because we actually identify a lot of subtleties that otherwise we miss.
Question from the audience.
PET scans which give us a non-invasive CFR. So in patients with an abnormal PET stress test with abnormal CFR, no epicardial obstruction or non-obstructive CAD on the cath, and if we don't have coronary system, is that non-invasive CFR combined with evidence of ischemia on the stress test and abnormal CFR enough to make a diagnosis of coronary microvascular dysfunction, especially if you don't have access to coronavirus?
So it's a great question. So the question about PET scanning, and I certainly think non-invasive testing is helpful. One of the limitations of our non-invasive testing is that we cannot calculate pure microvascular resistance because we don't have the distal coronary pressure. We can calculate, like you said, coronary flow reserve, which is nice. You have to be careful because there's different endotypes. You can have high resting flow that leads to a low coronary flow reserve, and I think we're still trying to learn whether that is true microvascular dysfunction or not. And then you can have classic low coronary flow reserve where you have normal resting flow and you have impaired hyperemic flow. I think in that setting, again, you have to assume that the PET scan's actively ruling out, or if you have a CT angio, epicardial disease, because you can have a low CFR from epicardial disease too. So I think these tests are helpful, but I still feel that the gold standard is in the cath lab.
Yader.
It's a great question. I mean, I think it's important that we collaborate with our imagers, interventionalists. We're in a little bit of a silo, and I was at ACC earlier this year. I went to the same session in CMD by imagers, and they were they just wanted to do PET and CMR. Same in the interventional side. There's a place for everything. The reality is you talk to your patient and you say, there's a low-risk procedure. The team has, and Olga have published this, less than 1% risk. The patients that have refractory symptoms and understand they want to do a comprehensive study, you bring them to the lab. But I think, to be honest, I sent a lot of patients. In our hospital, we can do myocardial blood flow reserve by both PET and MRI. You're missing the spasm portion and some other more comprehensive phenotyping. But I think it's a fair option, and there's a lot of data for myocardial blood flow reserve, and it allows us to communicate to our peers. A lot of the imaging community, feels, we're not on the same page on this, I will say.
And especially like in a low resource setting, if you look at the Coronary trial, you can use amlodipine for both spasm and microvascular dysfunction. So if you commit to that diagnosis of microvascular dysfunction, start them on amlodipine, they do okay. Maybe keep them on amlodipine if they're refractory, then refer them to a quaternary center for invasive testing.
Yeah, this is reasonable. I just want to say that AngioAid, this was an ad hoc testing by Javier Escanet. He showed that the prevalence of microvascular dysfunction is only 30% in these endotypes. The most common endotype is a mixed endotype between spasm and microvascular dysfunction, almost 70% of patients that present with ANOCA. So the testing for spasm is a very important component. Therefore, and some of the beta blockers we use for CMD are actually causing coronary vasospasm to get worse. So if you are selecting something, it has to be a vasodilatory beta blocker.
So actually one thing, for the people on the back, there are chairs on the other side if you want to go back there so you don't stand if you want to. And then any questions, please call and I'll get the mic to you and you can ask the question as well.
Okay, great. Well, sorry, we'll get one more question in. And then
Bill,
we'll
just can you elaborate a little bit about the two endotypes you mentioned? High resting flows versus normal resting flows with a hyperemic response to the CFR.
Yeah, sorry, what was the question about the endotypes?
So you mentioned that there were two endotypes, one with the high resting flows. Are there absolute numbers to define them, or they are relative?
Oh, so yeah, it's a good question. I mean, the cutoff point that people use is generally 2.5 for CFR, maybe down to 2. There's a little bit of a gray zone below which you have an abnormal CFR. And yeah, the high resting flow, I mean, I think you have to look at, for example, in the bolus thermodilution, normal resting flow is around 1 second. And so if your resting flow, is 0.5 seconds, then, you have high resting flow. So you don't, there's not an absolute cutoff, but you just have to look at the compared to normal values. But I think we should go ahead and move on. We have our last talk, going to be wrapped up by Tim Henry. No one better to give this talk, who's going to tell us, so what do we do with this information? How do we treat?
So delighted to be here, and it's set up well by Olga and Bill. So first of all, in disclosures, I am involved in the Shockware and Xylochlor trial, SPI with refractory angina, which does deal with microvascular angina. So this seems like an easy topic. Most interventional cardiologists believe there are no treatments for ANOCA. And does ANOCA really exist? Well, hopefully we'll change your mind on that. So this is a 62-year-old black female, hypertension, hyperlipidemia, came for a second opinion because she's had chest pain for 15 years. She has chest pain predominantly at rest, but also occurs when she exercises, and she has exertional dyspnea as well. And so her exertional symptoms were class 2. She's had 7 previous nuclear tests, 6 were positive, 2 previous echoes that were positive, 1 was positive, 3 caths all showed non-obstructive disease. And so this is a very typical patient. She's seen 4 different cardiologists, lots of angiograms, lots of stress tests, and you know what she doesn't have? A diagnosis. So this patient has been told they're crazy, and they get anti-anxiety medicines and antidepressant medicines, and we'll show you what we really have. Why do people have chest pain? So start with that. And so the arterial tree is complicated. You have epicardial disease, prearterials, arterioles, capillaries, and then each side of the vessels you have epicardial disease. You have microvascular dysfunction from a number of different causes, and then you have vasoconstriction. So this is a very complex. I first did my first test in 1987 with a handmade Doppler one, and I will tell you that it's become more and more complex, and I realize the interactions of this, and we'll try to show you that. So first of all, ANOCA is angina with no obstructive coronary disease. But it's not one disease. This is very complicated, and it's very heterogeneous. And even when you have microvascular dysfunction, you have epicardial spasm. But even when you have microvascular disease, there's endothelial dependent and endothelial independent. So there's significant overlap, and there's overlap as well along with the epicardial disease and myocardial bridges, et cetera. Important thing to know is these patients have poor outcomes. This is not a benign condition. It's not just that they keep coming to the hospital with chest pain and keep needing evaluation, but their long-term outcomes are worse. In fact, we just looked at a ANOCA STEMI patient, and the ANOCA STEMI population did worse than the coronary artery disease STEMI population, partly because we ignore them and don't treat them. So I'm not going to go through this, but invasive testing ultimately is the best test for this. Non-invasive testing is maybe okay for coronary flow reserve. There's a fair correlation, but you certainly can't get epicardial spasm. You can't get an endothelial dysfunction. And so the gold standard is clear to do invasive testing, and that involves angiogram, LVDP, adenosine testing to look at CFR and IMR, and then vasoconstrictive testing with acetylcholine. The order of which you do it varies, and we're not sure, so that's worth a topic. Why do it? Does it make a difference? So let's start with this, with the Carmichael trial, which is published a few years ago, that actually showed you randomized patients to doing a diagnostic test to know what you have, and then using that information in half the patients, but not using it in the other half of the patient. And at the end of the year, the patients that actually knew and you used the data did better than the patients who don't. Significant improvement in angina, improvement in exercise time, improvement in quality of life. So this is what changed it and put in the guidelines. This should not be surprising. If you know what you're treating, you do a better job at treating it, right? I mean, that's what we do, what we learned in medical school. But I think this is an important trial to show that. And we know in our angina clinic, we've done it in 2 different places in Minneapolis and now in Christ, that 85 to 90% of patients at the end of the year have less chest pain and better function than they do. So by looking at it, knowing their diagnosis, you can make a difference. So this is our approach. If you have exertional angina, if you have class 1 or class 2 symptoms, we start with empiric therapy, and we'll come back to the empiric therapy, and do non-invasive testing as needed. If you have class 3 or 4 patients, we start with empiric therapy, but we go faster to invasive testing if needed. If you have rest angina, we have a similar cohort, so we always start with empiric therapy. But if patients aren't better or they're having complications with medicine, then we go to invasive testing. And then, of course, most of the patients actually have mixed testing, and again, we're more likely to go quickly. But I'm currently doing between 5 and 10 tests per week, and if we actually had a low bar, we would be completely overwhelmed because there's a huge number of patients that fit in this situation. So most of our patients have failed empiric therapy and continue to have class 3 or class 4 angina. Now, when you look at the treatments, this is a broad look at treatments, and treatments are very complex because patients don't just have one box. Many of them have 3 or 4 things, and you have to design a treatment for that patient. We start with ACE and ARBs, been shown to work. We also start with statins with a goal getting the LDL less than 70 because your endothelium works better if you have your lipids are under control. For endothelial independent or abnormal coronary flow reserve, we start with beta blockers, and that's the mainstay, and then we use ranolazine. If you have endothelial dependent CMD, or if you have vasospasm, we start with calcium channel blockers. And in vasospasm in particular, we try to avoid calcium channel blockers. We frequently, once we know that you have vasospasm, you can have diffuse or focal vasospasm. And we will use 2 calcium channel blockers in that. I would never, or I seldom empirically do 2 calcium channel blockers. But once I know that this is what you have, then we easily do it and it works. So this is kind of the general one, but I will tell you there's lots of nuances. In terms of non-pharmacologic treatment, we do cardiac rehab and exercise training in all the patients. Weight loss is a really important, and psychotherapy medication we use frequently. And in terms of device-based therapy, there's really good evidence that EECP works. We just published data in microvascular angina patients that showed that 80% of the patients had improvement in their exercise time and a reduction in angina. And we also use the coronary sinus reducer. There's excellent data that I'll show you a bit in a minute. And then there's some data with cell therapy, but not available at the present time. This is the ECP. Physiology is just like a balloon pump. You increase diastolic flow when the cuffs are up, and then the cuffs come down and you decrease afterload. This is the data that we showed in 100 patients that again showed significant improvement in angina and significant improvement in exercise time. So it's really effective, and I personally think part of the reason it works for patients with obstructive disease is because it has benefit for microvascular dysfunction. This is actually into the guidelines in the European guidelines, which is surprising because there's less ECP done in Europe. This is the coronary sinus reducer that we're using now for obstructive coronary disease predominantly, but this is the INROAD trial that showed that you had a significant reduction in IMR, a significant improvement in IMR after using the coronary sinus reducer. And the feeling is that when you put it in, the mechanism may be a little bit different in that you increase your backward pressure in the venous system, and that decreases resistance. And then the important thing, so I'm going to end with this. These patients have a combination of epicardial disease, vasospastic disease, and microvascular disease. And it's important to know what they have and design treatments that are tailored specifically for them. This is actually shown, it's complicated, but it's worth reading these two issues that we had in Jack from the Microvascular Network. And then I'll end with this patient. So this is a patient who had gone with chest pain for 15 years. And you can see with giving acetylcholine, she had severe spasm in her LAD. This is the spasm on the left side and post-nitroglycerin, which normalized her coronary within 20 seconds. And then she also had abnormal coronary flow reserve with a CFR of 1.6. Well, this was by Doppler. So this is why the patient had both exertional chest pain and had a rest chest pain. And so she was titled, and this patient currently has rare angina after she's been treated. So this involves an angina team, and you work together. Our Women's Heart Program, our CTO program, and our refractory angina program all work together. We have a nephrologist, we have an endocrinologist, and we have an anesthesiologist that works with us closely. All right, thank you very much.
All right, we're pretty much running out of time, but any final comments from the panel? And a question from the audience.
Evaluation for a microvascular disease?
Yeah. So we don't do with first-time Takasubus, so that fits into a ANOCA category typically. But we have a series of people that have had recurrent Takasubus, and if you look at recurrent Takasubus, many of them turn out to have epicardial coronary vasospasm. So the answer is not routinely. What we do is just like with all ANOCA, we do a MRI within 72 hours, and if it confirms that that's most likely Takasubu, we treat them with beta blockers, but if you have recurrence, then we do invasive testing.
Yeah, just add on, we did a study a while back of IMR and Takotsubo patients, and coming out, I don't know if it's out yet or not, we have a meta-analysis of a number of other studies looking at IMR, and so Takotsubo, it is acute microvascular dysfunction, and the higher the IMR, the worse the outcomes.
Yeah, so we're going to close out this session. Thank you for your attendance. A reminder, there's a